first I want to make sure that it's something that can fit in their lifestyle, that it's something that they're willing to do. And then we often want to try to start with the least invasive techniques and the easiest things, and then move up in our intensiveness as needed. Certainly we want our goals to be developmentally appropriate. You know, I'm in pediatrics, so when I see a baby, the goals of a baby in bowel management are very different than the goals of a 30-year-old in bowel management. We tend to try to just have babies emptying regularly. Then as kids approach school age, we want to develop social continence. And then older school age kids and into adulthood, we also want to make sure that this is something that you can either do independently or with the level of care that you have access to. And then certainly, again, looking at everybody's abilities, what level of mobility is involved? Do you need a caregiver to help you? Is a caregiver willing to do certain interventions? And then having a contingency plan or a backup plan is important. If you're sick, if you're traveling, what do you do on gym days, or if you are really stressed out or taking antibiotics for a urinary tract infection? How do we tweak the bowel plan at that point? All right, next slide. And so then, again, thinking what is a bowel management plan? So a bowel management plan is really what we're talking about is trying to find a predictable way to empty the colon so that we take stool out of the picture and we don't worry about it for the rest of the day. And again, we try to accomplish this with the least invasive techniques and the easiest technique and the least time consuming techniques, and then go up the ladder as needed. So certainly starting with things like diet, time sitting, lifestyle modifications like exercise that Adam's going to talk about a little later. Then we add medications as needed. There's medications that just lubricate the stool, like Colace, or osmotic laxatives that draw water into the colon, things like milk of magnesia, Miralax, lactulose. The next level of medications stimulate the colon to contract, so it kind of pushes the stool through, things like X-Lax or Ducalax. And then moving forward, even our newer motility drugs, things like Motegrity, which really have an influence on the way the whole intestine moves. All of these medications, though, can be unpredictable, right? You take them by mouth, they go into your stomach, they need to dissolve, they get absorbed. And they work in a range of time. And also they can be difficult to titrate to a level that, is enough to go, but not so much that you're going copious amounts or having blowout stools. So that's when we start to think about rectal interventions, because those tend to be more predictable. Typically, rectal interventions start to work within 15 to 20 minutes. They can take a while to completely work, but they start to work fairly quickly, so they're much more predictable. So things like suppositories, little microenemas, or regular enemas. The downside of those is if you have poor rectal tone, keeping them in can be difficult. So then they are enemas that are specifically designed for folks with neurogenic bowel, things like the cone enema system, which has a cone at the end of it, which acts like a plug in the rectum. The difficult part of that is, unless you have very good mobility and you're fairly agile, they can be difficult to self-administer. So the independence part can be cumbersome. So then we start to think about things like transanal irrigations, and those go up a little higher too, so they tend to be a little bit more effective than traditional enemas. So those are things like the Peristine system, which is a catheter that has a balloon at the end and a manual pump that pumps fluid into the rectum and the lower part of the colon. And the Navina Classic also has a hand pump, and the new Navina, the Navina Smart, actually has a programmable pump, which I'll talk about in a little bit, that you can set to do the irrigation for you. Then if moving up from that would be something like a anterograde continence enema. This is a surgical procedure where the surgeon either creates an appendicostomy tube so that there's a catheterizable stoma through the appendix, through the skin, where you can put a catheter to intubate the stoma and give an enema from the top down. Or they go in and they create some sort of a conduit in the colon, typically like a little button, like a little feeding tube button, that you can also give enemas through. And then if all else fails, we consider a diverting ostomy, where you just take the colon and the rectum out of it, and you create a bag where the stool gets collected. Right, the next slide. So that brings us to the questions that we received in from the last time. So I can just go ahead and start reading them. So the first one was, how does exercise help neurogenic bowel? I'll just say very briefly, and then I'm going to turn it over to Adam, who has extensive experience in this. But we know that there's something called the gastrocolic reflux, which is a reflex that the body sends to the colon, which gives it the signal to empty. And three things really trigger that. That's eating, waking up in the morning, and exercise. And so these are things that we can use to kind of help us time a bowel plan around. That said, like I said before, sometimes exercise can make the colon move too much, and then we have to worry about accidents. So it can be kind of a little feast or famine. Certainly aerobic exercise can be helpful because it puts a little pressure on the intestine to help things move through and increases colonic motility. And of course, doing abdominal exercise, building those abdominal muscles and those pelvic floor muscles can also help us with pushing. But again, I'm going to pass it over to Adam at this point.
Yeah, so in my experience, like Fiona said, abdominal exercises help me stay pretty regular. It helps me not get too constipated or anything like that. But also controlling what I eat. Sometimes eating too many spicy foods can have, too much diarrhea. Too many carbs can cause constipation. Too much cheese, things like that. I try to do as many sit-ups as I can to keep that going. I know some exercises may not seem like your core is exercise, but it is. Majority of the time, your core is worked out. So as long as you're staying active, it can really help keep the bowels regular.
All right, so moving on to the next one. Oh, go ahead. So.
No, just going to say thank you, Adam. I was just having trouble unmuting myself, but yes, you're doing fine. Please keep going.
So the next question was, do you ever experience pain when your bowels are full and you're ready to catheterize? So certainly, if you think about the way that the colon is shaped, there is the last part of the colon, which is called the sigmoid colon, is kind of a shelf that stool, if you're constipated, tends to fill up and stretch a bit, and that can push up against the bladder. So it's not unusual to have either difficulties catheterizing or leaking of urine or urinary retention or sometimes discomfort if you have constipation and you're catheterizing. But this is asking if you guys ever experience pain, so I'll send it to you guys.
So I definitely do. I have a tendency to have bladder spasms if I am very constipated and then there's movement happening. So a lot of times when it happens is, first thing in the morning when I wake up, if I'm, not empty and I'm feeling kind of constipated and backed up, first thing in the morning, I always have to empty my bladder anyway. But let's say, I'm lying there and I didn't get up right away. It usually does lead to a bit of a bladder spasm. Fortunately, I have an artificial urinary sphincter. And I've had one since I was very, very young. fortunately, now it doesn't lead to having an accident, a urinary accident. It has in the past, but fortunately that doesn't happen anymore. A lot of times too, if I'm having a bowel movement, and it's on the larger side, it does cause some pain and spasms, and it will maybe cause me to leak a little bit too. And the pain is there, but it for me, it's not like alarming, but there is a spasm there that can be kind of painful.
For me, I've experienced pain here and there. I try not to let it get to that point. I try to stay pretty regular. I don't know if I would describe it as pain, more of just pressure and just the urge to really have to go. And usually by then, if I'm feeling it, it's like I've waited too long. And so that's why I've tried to limit how often I felt that. And it's been extreme circumstances. But yeah, from time to time, I might get that here and there.
Then the next one kind of ties in with that as well. Is it my imagination that I feel that I have to cath more often when I'm constipated? And so again, that makes sense, right? Because if you have a lot of stool in the colon that's pushing up against the bladder, there can certainly be, it can diminish that bladder capacity. So you're having to really catheterize more frequently. You can have leaking. So it's not your imagination. This is a very well described phenomenon.
And then as a woman too, you know, that time of the month can mess things up. So, you know, that kind of affects all of it all at once. And it definitely, for me, at least, and it causes me to feel like I need to cath more often, or just to really need to cath more often.
Great. So then the next question was, I'm in my 60s and I have a urostomy bag. Does having a urostomy interfere with getting a colostomy? So this is a difficult question, right? Because it's very specific, and certainly I can't answer it specifically without knowing more about you. And so I think this is a conversation that you need to have with your providers, making sure that colostomy does make sense. And then also making sure, you know, talking with your surgical team and your urologic team and your GI team to see what can be done. Because certainly having had previous abdominal surgery does make things difficult, right? Not just from a space standpoint, but also what have they used? You know, certainly for folks who have a metrophenop, they've used the appendix oftentimes, and then if we want to use the appendix for a cecostomy tube, or an appendicostomy, we can't. For a urostomy, did they use ileum? For a bladder augment, did they use ileum? You know, it definitely limits sometimes what you can do. So I think it really highlights a very important point, that when you're going to have a procedure for either a urologic procedure or a bowel procedure, it's very important to have that conversation with your surgeon, with your providers, and say, you know, I'm thinking of having a metrophenop or whatever the procedure is. What do you think? Is there something for my bowel that I should do at the same time? Because where I am, we're very fortunate that I work in a multidisciplinary spina bifida center. So we are able to have these interdisciplinary discussions about patients that, you know, the urologist might come to me and say, listen, I'm thinking of doing this. What are your thoughts from the bowel perspective? And I'll say, you know what? Wasn't really thinking about an appendicostomy tube now, but maybe this is the perfect time. We can use the same anesthesia. If they have an unusually long appendix, we might be able to share the appendix. So it's just nice to be able to have those types of conversations. So I think better to have the forethought if we can. But in this specific case, I would certainly discuss this with your care providers. All right, and that's all the questions on this slide. So then moving to diet and nutrition, what are specific examples of dietary restrictions? So I never say that things are restricted per se, because it's, you know, I think it's up to the individual to see what what foods maybe have an impact on them, and then saying, and I'll give this over to Adam and Amy in a second too, but certainly everybody realizes the foods that may be a problem for them. I have some patients who say, oh, every time I have chocolate, I get I get diarrhea, or I get constipation, or every time I have fried food, this happens. Or I think Adam had said earlier some of these things. And so I think that knowing what's specific to you, and then knowing that, okay, so today I'm giving a presentation for work, maybe it's not the right day to have those foods, but tomorrow is maybe a day that I have off. And so there's a little bit more leeway there where I can do that. So I hate to say that anything's restricted per se, but I'll hand it over to you guys and see what your thoughts are.
Yeah, just exactly like how Fiona was saying, you have to figure out what works for you. When I was starting to work out, I found out about the keto diet, and that one's low carb. It's a lot of fats and things like that, but it's also a lot of greens, vegetables, making sure it's balanced. And that works for me. But do I recommend it for everyone? No, because people love their breads, their pastas, and so on. It's a matter of what you can stick to and how your body reacts to certain things. I love spicy food, but my body doesn't love it. And so I know that causes me diarrhea. And I know that kind of leading into that second question, you have to remember how your body reacts to certain things, and it may take some time, but just paying attention, like, oh, last time I ate this thing, this is how my body reacted. And, you might hear of fad diets and different things like, oh, you have to try this, or you have to try that. It's all about what you can stick to. That's what matters. So if you can do keto diet and stay off the carbs, that's great. If you can do vegan, vegetarianism, all that, it's what you can stick to, what you like. That's what you have to figure it out.
And like Adam said too, I completely agree with what you said, and it's all what you can stick to, what you want to stick to, what goals you have. If you have weight loss goals, if you have goals where you want to lower cholesterol, whatever it is, you definitely want to make sure that you're paying attention to your body. How you react to these foods, how you react to whatever diet it is, and being careful of the, if it is a fad diet, it works for some people, it doesn't work for everyone. Everyone has different opinions about it all. And definitely, talking to your doctors about it. And one tip that I've gotten to is to keep a food journal. So, keeping track of your meals and what you're having, and also how you're feeling, of your bowel movements, what they look like even. I mean, getting as detailed as you can and tracking it for, like Adam said, it takes some time. So maybe over a week, over a month, whatever it is. And that will really help you keep track of what foods are good for you and what foods aren't. It was pointed out to me recently by a doctor that I might want to try going gluten-free. It might be affecting my bowels, my anxiety, some skin issues I'm having, all sorts of things that are all like interconnected. So again, it's a really great thing to have a conversation with your doctors about in keeping track of your foods.
Great. And I think the next two questions, if you want to move on to the next slides, these two questions about how does one determine what foods trigger diarrhea and what are the thoughts on FODMAP diet, I'll talk about in a minute. And this other one as well, I think this kind of links in with the other ones. So it says, I take probiotics and Benefiber every day, but often have to take prune juice to keep me cleaned out, often resulting in, it's lost, but I think it's an explosive stool. I tried Miralax and did not feel good when I was on it. Any suggestions for a simple and effective daily program? So again, this has to be very individualized because it's hard to say over this what's going to work for you, what's not. But simply, I think oral medications are the easiest if they work effectively. Oftentimes the kind of osmotic laxatives or the osmotic foods, draw water into the colon, and you either get this feast or famine that you're describing. So Miralax, prune juice, that kind of stuff don't always work that effectively. So I think maybe if you want to keep it to something that you're taking by mouth, trying a stimulant laxative might help to just empty you more predictably. So like a Senna or a Ducalax. And if that doesn't work, then I would probably start to talk with your care provider about something rectally that you could give yourself, because those again are much more predictable than anything orally. So then moving to the next slide. Oh, sorry, go ahead.
I actually just chime in for a second. I actually have found with myself too, and like you've said, everyone's different, everyone's body is different, but I also think, you know, we change throughout our life as well. So like what happened, or what worked for me when I was younger, I used to take Miralax a lot, used to take Benefiber almost every day. But then it got to a point where I just couldn't anymore. It was leading to blowouts. It was leading to a lot of issues. So I've kind of tried to find like a sweet spot. So I take probiotics instead of every day, maybe about 3 to 5 days a week. You know, Benefiber a couple of days a week. So just playing around with what you're using already is an option too, I would think. But correct me if I'm wrong, Fiona.
No, I think that's absolutely right. It's often just kind of titrating on your stool consistency and trying things. The Miralax too, I mean, the biggest side effect we see from Miralax is accidents, because it can make the stool really loose. And when you say you didn't feel well from it, we see that a lot of people get very bloated from Miralax, even though it says that it's non-bloating on the bottle. I mean, it is bloating. Sometimes things like milk of magnesia are a little bit gentler. So it is kind of a trial and error. But again, for simple, sometimes doing something rectally is easier than doing something unpredictable from above. Okay, so then talking about the foods that might trigger diarrhea. So these include things like the osmotic carbohydrates. So again, osmotic meaning it draws water into the colon. If we think of what the colon's job is, it's to move the waste down to the rectum, but it's also, its other job is to draw water out of the stool so that we don't get dehydrated. Osmotic things draw the water back into the stool so that it's softer. So foods that are high in fructose or high fructose corn syrup, things like apples, pears, peaches, cherries, those things, those are the natural ones. They bring water back into the stool so that if you eat a lot of those, you can get diarrhea. That said, we use those often, particularly in my practice with very young children, that we want to control constipation with. So we always tell them try the pea fruits first, because those draw water into the colon and can make the stool softer. High fat foods are another thing that's highly reported as causing diarrhea. So again, not a complete taboo if you have to, you know, you're going out, you have to have that fried chicken. Just knowing, okay, I'm having fried chicken, I might have a blowout of stool, I might want to give myself some extra time on the toilet, or I might need to do an enema, or I might need to take an Imodium to slow things down. Just being aware of what's going on. And then high fiber, that can go both ways. So fiber tends to bulk up the stool. It draws water in, but it also adds bulk to the stool. And so we see folks who run the spectrum, go from diarrhea to very constipated, depending on their fiber intake.
Fiona, I have a quick question. When you were discussing the osmotic carbohydrates, you mentioned that in your practice, you recommend the pea fruits.
Oh, yeah.
Are those
like pears, peaches, plums, those kind of things? Yes. So for like our babies, when they're starting to do baby foods, we always will say, you know, try those fruits that start with P, the letter P. Yes, I should have been more clear with that, because those tend to be the more osmotic fruits that when they take, their stools will be softer.
Okay, great, thank you for explaining that. Okay, are you guys ready for the next one?
Yes.
All right.
So then the next question was talking about about the FODMAPs, and this is an interesting thing. I actually talk about this a lot in my other world, which is talking about functional gastrointestinal disorders, so things like irritable bowel syndrome. And these are your fermentable oligosaccharide, disaccharide, monosaccharides, and polyols. So what is that? They're short chain carbohydrates, and they're sugar alcohols. and they're very poorly absorbed by the intestine. So they, again, will pull, they're osmotic in their nature, so they pull water into the colon, but a lot of them are also fermentable, so they produce gas. So you can have a lot of bloating and diarrhea from these. And some people can be much more sensitive to them than others. The problem with this, and so, you know, some people will go on a very low FODMAP diet. The difficulty with this is they're very healthy foods for the most part that we don't think about. A lot of them are fruits, vegetables, all your kind of dairy drinks, because lactose is in there. So if folks are really concerned about FODMAPs and they worry that this may be triggering some diarrhea, we certainly recommend working with a nutritionist if you want to try a low FODMAP diet. In our practice, we will do a kind of a FODMAP, a very low, strict FODMAP elimination diet in some folks, and then start to add them back in to see which ones that they're sensitive to. But again, this is something that really should be done with an experienced dietitian, because you are going to be eliminating healthy foods and you want to be mindful of it. And I think if you take into consideration, and again, I'm in pediatrics, so I'm always worried about nutrition, that there's sometimes with Chiari malformation, there's a very specific food likes and dislikes and texture likes and dislikes. So it's very difficult to think about limiting foods if people don't have a wide spectrum of foods that they're taking. So I just think that folks should be very mindful of this, so mindful of the dietary stuff, not going overboard, because we want to make sure that everyone's getting adequate nutrition.
And I have a question also about the FODMAP foods. Is there a place, like if people wanted to look up, you know, what are some foods that fall into this category? Like what might be a resource other than, you know, speaking to the nutritionist, like if they just wanted to go online or?
Sure. There's a very good book out there by a nutritionist, Karen Warman, which I can send you the information on. I don't know if you can distribute that somehow.
Yeah.
That talks about the FODMAP diet. But like I said, it's really in a lot of things. There's you know, it runs the gamut from dairy to fruits and vegetables and grains. So really there's a lot of, and garlic, and I mean, there's lots of stuff out there that fall into these food groups. But I'm happy to send that information along. But if you just Google a low FODMAP diet, you're gonna see there's usually a chart that will come up that talks about all the different groups.
Thank you. Yeah, and that we can definitely include that in our website in the archive when you look at if you're looking for the recording of this and also the additional resources, we'll be sure to add that resource to the list. Okay. Oops, hold on. There.
Okay, so the next question is, I'm curious about trying the ACE procedure. So again, ACE meaning an antegrade continence enema. Should I speak to my urologist about this? And yeah, absolutely. If the urologist is the person who you're really comfortable working with, who's been your primary caretaker in your continence issues, then this is at least where you want to start having your conversation. They'll likely recommend you to talk with a general surgeon. And I certainly recommend, if you do end up having an ACE, that you're going to want to have somebody on your team who knows a bit about ACE flushes, because where it seems very simplistic, you know, you're putting a port of some sort in so that you can give enemas from the top down. Oftentimes, we really need to tweak the flushes both in volume and what we're putting in there to make sure that they're effective. That they're effective in that they get enough out, that they're effective in that they don't take forever to work, that they're effective that they don't get absorbed into the colon, that they're effective that you're not having accidents afterwards, and that you're not getting too much cramping when you're doing this. So there's a lot of stuff that goes into making an ACE flush successful that I think, and I don't want to scare people away from this, because when they work well, they can work fabulous and they can be life-changing for people. But I think that absolutely getting as much information before and after the ACE procedure is very important. And I don't know if either one of you want to weigh in on the ACE at all.
I had the ACE procedure done in, I want to say 2006. So I was a junior in high school when I had it done, and the goal of it was basically so that I could be independent with my bowel routine, because my goal was to go away to college and not live at home and not live too close to home either. So when I went to school, I was 2 hours away from home, and it worked in that it did give me the independence. So like I said, I had it done as a junior. So we had from that time up until, the end of my senior year and that summer to kind of really play around with it. So like Fiona said, you'd really need to, most likely your first, second, third try of, the amount of fluid you're putting in, the ratio of whatever you're putting in. I believe I was using saline solution and something else. It was a long time ago. I don't exactly remember, but we really had to play along with it. And again, I actually was at that time keeping a journal as well of what time I put the fluid in, what time I started to feel cramping, what time I started to go to the bathroom, what did it look like, what consistency was it, and was really detailed with it, bringing that back to my appointments. And it helped us change things up to where I got to a point where it was successful enough that I felt okay with it. That being said, I did have a lot of blowouts with it. I don't know that I ever really got into a good routine with it, but it served its purpose for, throughout college, and then eventually, and this leads up to the next question, I did let it close up. So what happened was I had the one where it was the pentecostomy, is that right? And attached to a stoma on my abdomen. So it was on my side, so next to my belly button. And so I would catheterize through that. And I did have it start to close up, so that I had an issue with inserting the catheter there. So I had it reopened in the emergency room at Children's Hospital. I remember it wasn't a whole procedure. They were able to do it just, at the skin level right there. But then in the future, I let it close up again, and I would have needed surgery again to have it reopened. And then now I switched to something different. I decided that it wasn't working for me anymore, but I've met many people where it was very successful for them. And like Fiona said, life-changing, and I don't want to scare anyone away from it. I think it's a great option.
Yeah, so I think with the ACE redo question, like Amy said, that is one of the things that we do see, that because if you think of the way the skin is, it tries to heal down and shrink down around that hole. So we do them either off to the side, like Amy said she had hers, or we do them right in the belly button. Oftentimes, if you have a Mitrofanoff, it's hard. You can't put both the Mitrofanoff and the ACE in the belly button. So we we'll put one to the side, one in the belly button, but they will sometimes close down. And when that happens, they do have to go in and kind of dilate that open again. Certainly, sometimes we try to prevent that by having people keep a catheter in place or intubate it even if you're not using it. The other thing that we sometimes see is the opposite, so if you're thinking about when they do the ACE, what we hope for is that there's enough bulk underneath it that it acts like a one-way valve, so that when you're putting the catheter in, you're breaking that seal. And when you take the catheter out, it's kind of bulking back up again so that you're not leaking stool contents and flush out. But some people, they don't heal properly around there, and there's not enough bulk, and they can have some leaking. So sometimes they'll have to go in and put like a little bulking agent to fix that. But typically the revision type things, it's not a complete redo unless you let it completely close up, but it's not a complete redo. It's usually just a revision per se. So then I think moving on to the next question was, would you ever add something to the ACE, like using a milk and molasses enema? So I have never used milk and molasses in an ACE, and I sent a query out when I got this specific question to see if anybody else had used milk and molasses in an ACE, and nobody had. This was in our motility center, and through a listserv that I'm on our GI group. That's a national GI group. However, I constantly add things to the ACE solution. We typically start, like Amy said, with a saline flush. That's usually what most folks go home from the hospital using, is just normal saline in the colon. We typically don't do just plain tap water because that can get very easily absorbed into the colon. It can cause an electrolyte imbalance if you're using large volumes, and even if you're not using large volumes, if it's really getting absorbed into the colon, it's not going to work very well. Saline also gets absorbed, so it often doesn't work as well. And I'd say that there's very few people who continue just to use saline alone. The first thing that we usually switch to is something like Go Lightly, which is less readily absorbed into the colon. And then we start to add additives, particularly to make things go faster, which kind of will address the next question a little bit. But we give like irritants or stimulants to make the everything go through faster. So things like, or more effectively as well. So things like, I'm blanking. Castile soap is something that we use. We use a lot of liquid glycerin and bisacodyl, all those kind of things to really kind of stimulate and make the flushes more effective.
I'm curious about something. And interesting again that you hadn't heard anybody else, any experiences with milk and molasses, but I'm wondering, are there any like warnings, or do you think of any potential dangers of using that milk and molasses?
No, I don't know of any actual warnings of using it in the colon. So I had to actually look up what a milk and molasses enema was, although I've certainly heard of it before, but not having used them. So you use evaporated milk and molasses to make kind of a sticky enema, which seems like intuitively would work fairly well from below, right? Because from below, you're thinking of bulked up stool that you're trying to melt through to get things moving. Where I don't necessarily see that it would be a problem from a complication, I don't know if it would be difficult to get through an appendicostomy tube, if there might be some blocking in that area, just from putting something really sticky through the tube itself. So that I think might be difficult.
Okay, thank you. Just curious.
Sure. So then I think the next question was, again, how long should a child, and they put in parentheses, age 8, need to sit on the toilet after an enema? So I think we can kind of expand this out beyond age 8. So I think there's two questions: how long will they sit, or should they sit, and how long will they sit, and how long should they sit? So those are two different questions. And one is, if you got a little kid with ants in their pants, they're not going to want to sit for a very long period of time, which again goes back to making sure that a bowel plan is more suited and individualized for everyone. But then how long should they sit? And certainly there's reasons we don't want people sitting very long periods of time. We don't want people sitting and pushing too long and causing things like rectal prolapse, sores. So I really like to keep it within an hour. And I know an hour even seems like a long commitment of time, but we hopefully, if it's something like the ACE, you might not need to do it every day, but if they are doing an hour every day, maybe you can that's the time that you can have some screen time or do your homework.
And life doesn't stop.
Sorry.
No, that's okay. That's fine. It happens.
So So yeah, so trying to confine it at least within an hour, and trying to figure out ways to get people to comply with the sitting time. Then I think moving on to the next one, unless anybody wanted to add to that. Right, so moving on to the next slide. Okay, so the next question, yes, this is near and dear to my heart as a medical professional. Just getting anything authorized and how long we spend getting anything these days authorized is from insurance companies is difficult. But are you still having major issues with insurance authorizations with things like Peristeen? So sure, definitely it's difficult. I will say that the only insurance now, and for full disclosure, I'm in Massachusetts. And so our Medicaid, which is called Mass Health, that's the one insurance company that I have not, despite multiple conversations with the medical director of Mass Health, got them to cover it. This is one thing that I really am still working on, but I was actually in a conference in Chicago recently, a couple weeks ago, and met with a colleague from Florida, and they get their Florida Medicaid to pay for Peristeen, even in folks who have just functional constipation and no underlying organic etiology. So my hope is if we can get some of their data, we can start to get our local Medicaid folks to get on board. But at least in Massachusetts, with having a good letter of appeal and putting the right things on the forms, we've been able to get things authorized. For the folks who cannot get it authorized, they don't have insurance, or they don't have or all they have is Mass Health for insurance. We have had some folks buy it out of pocket. And for those people, I will tell them, reuse the catheters, because the catheters are the most expensive part of the system. Each catheter is about $65. So that's where the price is. So, buying the whole system with about 15 catheters is a little under $600. It's cheaper if you buy it in Canada. And then just reusing and washing those catheters, they're not going anywhere sterile.
To add on to that, so I'm in Massachusetts as well, and Fiona helped me actually get my Peristeen several years ago, and I think I remember you suggesting the same thing, using a limited amount of the catheters. The issue that I had wasn't with the insurance. I used Blue Cross Blue Shield. But the issue was with the medical supply company, so I couldn't use the one that I was currently using for my urinary catheters. I had to switch over to a different company that would supply Peristeen with the other catheters together. So that was kind of an issue for me, because I hadn't really had luck with that other medical supply company. So it's another barrier, but it's just something that you work with.
Yeah, I think the insurance companies are difficult with all supplies, and as are the supply companies a lot of the time. And then the next question is, are there other rectal and transanal irrigation systems on the market? So the Navina, which is what I was talking about earlier, they have now the Navina Classic, which very recently got approved in pediatrics, and they have a pediatric catheter as well as an adult catheter. It's a very similar system to the Peristeen, with the exception of it has two pumps. So one pump inflates the balloon and one pump pumps the water, whereas Peristeen has one pump and a dial that you turn depending on what you want to pump. But now they have the Navina Smart, which when I first saw it, I thought, oh, it's a little programmable device that you set the rate, you set the balloon volume. And my initial reaction was, oh, there's a lot that can go wrong with this. anytime I see these kind of like digital technology, I think, well, this could break, that could break. But what I do see that might be helpful for is for, you know, like I said before, I think folks who have a hard time, because you know, certainly the peristeen sometimes does not stay in the rectum of people, even with the balloon inflated, because of their rectal tone. So some folks have to hold that catheter in place. And so then you're holding the catheter in place with one hand and you're trying to pump with another hand. Now you have no hands left if you need to hold on to the commode or anything else. So I think for the folks who have to hold the catheter in place, this might actually be brilliant, because you can set the balloon volume, set the pumping, and now you're not using this hand, so you've freed this hand up to do whatever else you need to do. So again, I don't have much experience in that one. I'm just getting some experience now.
Just out of curiosity, Fiona, would you say that one is kind of like less cumbersome? Like, I just feel like with the peristeen, you know, there's all sorts of tubes and knob, and like there's just a lot of like moving pieces. Would you say
it's definitely sleeker. I don't have enough hands-on experience with it to say that it's less cumbersome, but I think it might be. Yes, I do think it's sleeker. It's a new generation, so I think they've taken some of that out of the way, and I think it might be easier.
Cool.
And Fiona, we had a question. What was the cost of the peristeen again, out of pocket?
Sure. So if you want to get the peristeen system and the 1 month supply kit, which it comes with 15 catheters and a replacement bag, that runs right shy of $600, unless you get it in Canada, and then it's around between $200 and $300 US.
Wait, that much less?
It's significantly less to get it in Canada, and you don't need a prescription to get it in Canada. So if you can find a website to buy it from Canada, we've had some families get it there. It's the exact same thing. It's European made, so it's the exact same system. So yeah, and then there's certainly some folks who can get, I know our Spinal Benefit Association that Amy's on the board of, and I used to be on the board of directors for, will give a stipend sometimes to families for medical supplies. So we've had some folks use that stipend towards buying it out of pocket. So there's creative ways to think of how to get it. And again, just washing and reusing those catheters.
Okay, wow, that's really good advice. And again, maybe, you know, this is something that one could research too, but if you were to buy, is it possible to buy just the main component of the peristeen without the catheters? Because you said that those are the most expensive.
They are, but you need catheters, right? So you need at least one catheter, and then that catheter is eventually, the problem is the balloon does eventually go on it. So you do need some replacement ones. I always say it's like when you buy a razor at the store, and the first razor that comes with 2 or 3 razor blades is fairly reasonably priced. And then you go back to buy replacement razor blades and they're locked behind like a locked unit because they're so expensive. So it's the same kind of thing, but you still need the razor blades to use the razor. You still need the catheters to use this system, but you don't need to use one a day. Peristeen or Coloplast says that they are a single use only. And the reason why they say that, well, I think it's because it's financially beneficial, but the reason that they give for them being single use is, one, there's a lubricant on there that activates when it gets wet. So the first time you use it, that will self-activate once it gets wet from the solution. Once you've used it once or twice, it's not going to activate anymore. So you need to put a lubricant. We recommend anything but Vaseline, because that can eat away at the balloon. So whatever you're using to catheterize with, Surgilube, any of those things are good. And the other thing is that eventually the balloon will go. It's not going to explode in your rectum, so it's nothing frightening, but it just won't inflate.
Okay. Well, thank you for that. So I'll move on to the next slide. And yeah, and so this is a time when you can ask your questions. We actually have an extra question right now. But what I thought we could do in the meantime is maybe we could just review some of these additional materials, and then, you know, if Fiona, Amy, and Adam, if there's anything here that you don't see that you think that we could also mention, then, you know, maybe we can do that. But so one of the resources that we have is the Spina Bifida Association has a booklet on bowel management and spina bifida, which you can just send me an email, and I can arrange to have it sent to you. And then we also have a couple of resources that were suggested by some in the group, which bear with me as I open them because I might have some technical issues. We have bowel management, and can you see that? No, you can't, but you can see that. It's Bowel Management with Spina Bifida, an unofficial guide by and for parents. And I don't remember who suggested this. Did anybody want to say anything about this particular resource?
It wasn't me, but
It wasn't. Okay. Who shared this with us? I don't recall. Okay. Well, we'll move on to the next one.
I might have found it, but I don't know that I actually. I'm not sure. It looks kind of familiar, but not. I don't know.
Okay. Well, all right. Well, that's fine. Well, that's one of them. And then let's see here. Oh, wait a minute. What just happened? Excuse me. User error. Where is it? Is this it here? Nope. No. What? Here we go. That's the one. Wait a minute. Okay. Why am I frozen? Sorry, everybody. Give me just a second here. Okay. Okay, we're just going to drop down to the next one. Okay, and then the other ones, there were a couple of Facebook groups that were mentioned. Bowel Management for Spina Bifida, and Bladder and Bowel Care. And what you see on the screen, these are the actual names of the resources, of the Facebook pages.
Yeah, so if you just type those in, it should come up with the group, and then you can request access to them. I think they just ask you like a couple questions just to verify that you're someone who would would benefit from the group and you qualify kind of to be in there. But it's a really great thing. There's a lot of parents in there of kids, but there's also a lot of adults in these groups, and it's a really helpful resource just for like asking personal questions and things like that, and some advice.
Great, thank you.
And I think that makes me think of, you know, certainly sharing and talking about the stuff like we're doing now, but also in these kind of groups is so helpful. I mean, you want to be careful about some of the information that you get, making sure that makes sense for you and that it's safe. But you know, you can learn so much from what other people have done, and then share that with your health providers. I've learned so much about what I do from you all. You know, coming in and you know, we try something, it works or it doesn't work, or you've learned something from somebody else, and then we say, oh, let's try it together and see how it goes. And then so it's you know, it's definitely these kind of sharing forums can be helpful.
Okay. And actually, we have a question that just came in, and this is the question. I have been told various things about the dependency of stimulant laxatives, like Dulcolax, etc. Some say that you can become dependent, and others say not. Are they habit forming for the bowel? And does it even matter for someone with neurogenic bowel?
All right, this is a very good question because we hear this a lot. So there's a couple things that I'm hearing in this. So one thing is that the medication that was in the stimulant laxatives years ago was habit forming, kind of addictive. So that, not addictive in terms of like an opiate, but like habit forming that once you started using it, then you kind of couldn't go back to not using it. those active ingredients have been removed from stimulant laxatives. So they no longer have those per se. That said, I mean, I think anecdotally people experience when they've been using something for a long period of time, their bodies tend to get used to it and maybe it doesn't work as well. Where we certainly wouldn't recommend necessarily that somebody with, no organic etiology is using enemas all the time or stimulants all the time. It is very different for somebody with neurogenic bowel. And, I think you need to, we always look at, in my business, kind of risk benefit analysis, right? And we want to make sure that that the colon is emptying regularly, because if we know that if you're very constipated all the time, that can have a negative impact on the bladder. It can also have a negative impact on the function of the colon, so that if it's always being stretched out, similar to, we liken it to like a balloon. If you're overinflating it all the time, it loses that elasticity and doesn't work as well. And so we want to preserve whatever function we can get. And so what if we have to do that with the use of stimulant laxatives? We're not afraid to use them long term. So yes, I think it's okay to use a stimulant laxative with your healthcare provider on a routine basis long term.
Thank you, Fiona.
Sure.
Does anybody have any other questions? We'll keep going through the materials just a little bit, and if anything else pops up, we'll ask it before we wrap up. So yeah, there were the Facebook groups, and then just information. When you go online to our website, to our archives for SBU, you'll be able to see these resources, and then you can also do some extra reading on Peristeen. And Fiona, was it Navina that is the product by WellSpect?
Yeah, exactly. So Peristeen is by Coloplast, and WellSpect makes the Navina and the Navina Smart. Okay.
And the one that you were referring to, was it the Navina or the Navina Smart, or either?
So the both Peristeen and the Navina Classic have a handheld pump. Peristeen has one pump, and WellSpect, the Navina Classic, has two pumps. And the WellSpect Navina Smart is the one that has the programmable pump.
Okay, cool. And actually, we have one more question. And this one says, I use a stimulant laxative on a weekly basis, and 1-2 times because of a shunt revision. They used a rectal enema in the hospital and it did not work well. Is this because of antibiotics and I should try it again? Or would it be a safe bet just to stay with the laxatives on a weekly basis? Let me know if you want me to read that again.
No, I got it. So it really depends. So you're saying you're using a stimulant laxative once a week, and we have some folks who do that, right? Who are doing something else through the week that they're emptying, but maybe not emptying fully. So I think of people who are maybe time sitting or doing some digital stimulation or manual disimpaction during the week. And, so they're emptying and staying continent, but they may be getting some stool buildup. And so then once a week, they'll take a stimulant laxative and be on the weekend and empty more, empty more out. And that's totally fine if that works for you. Now, the thought of the enema not working when you had it during the shunt revision, and of course that can be related to multiple things. One, certainly traditional enemas often don't work that well in folks with neurogenic bowel because of the way that the responses of the nerves and the muscles of the rectum, that tone is open, that those sphincters are open, and so oftentimes it just goes in and comes right back out. So it may not have stayed in long enough to really work. It may not have been large enough of a volume to get up to where the stool was. It may, not sure what was in the enema. Was it just a saline enema? Was it a saline enema with something that, with like glycerin or mineral oil or something to kind of stimulate and soften things? So if what you're doing now is working great, I guess this is my answer. If things are working well the way you're doing it, great, fine. If they're not working well and you think I want to maybe consider a rectal plan or an enema plan that might make me more predictable or might make me empty more, then I would talk to somebody about an enema plan and try to figure out what specific solution would work well for you.
Okay, cool. Well, thank you for that, Fiona. So we have it's about 7:34 Eastern. But yeah, just a couple more materials just to review. The bowel function and care guidelines, and then you could just select the age group that you're interested in, and that's also on the Spina Bifida Association website. And we've also got a link to Adam's exercise routines and what has been working for Adam to help with his bowel management routine. So that's what we have. And do any of the presenters have anything else that they'd like to add and mention?
No, I think that's it. I mean, I loved fielding your questions, and if there's other questions, I'm happy to, if you send them in like people did before, happy to respond to them. But I just think the most important thing is talking about these issues. Nobody likes to talk about bowel issues. Talking about them with your healthcare providers, talking about them with your peers who also may be experiencing the same struggles and maybe have figured out ways to get through them. It's a really important conversation to have. That's it.
Yeah, thank you very much. And and that actually also brings us to the resources, the Facebook groups, and just in terms of just having that conversation and just being open about it, and also too obviously with your providers. So. Well, I don't have anything else. Oh, go ahead, Adam.
I wanted to say, if for anyone who wants more updated workout videos, my Instagram is up to date, and you can find me at SB_inspiration. And I post those daily, weekly, and you'll see regularly how I change my routine. Great.
Thank you, Adam. Thanks for that. All right, well, I don't have anything else. So again, thank you very much, Fiona, Adam, Amy, and all of you who joined us. We really appreciate your time. And thank you so much, and I hope you have a good rest of the evening or afternoon, depending where you are.
Thank you.
All right. Thank you.
All right, take care.
Bye.
Bye-bye.